rest of the topics. It is my great pleasure to introduce Dr. Jessica Otte to you. You can see her picture with the turtle on the screen. My first time I met Jessica was when we did a road trip for a TI teaching tour in Williams Lake and 100 Mile House. And ever since then, I've been so happy to spend as much time as I can with her. She's a member of the TI and a family physician in Nanaimo, BC, with a practice focused mainly on palliative and geriatric care. She cares for her patients a lot with significant pain and is passionate about ensuring her patients get the most appropriate high-value care according to their goals and the evidence. And as I'm approaching my older years, I think I might move to Nanaimo because I would be very happy if she was my family doctor. And with that, I'll pass it over to you, Jessica.
Thanks, Aaron. I'm just going to share my screen and we'll get rolling. Is that working at your end?
Yeah, it looks great.
Okay. So let's jump right into this, what some would probably call an awkward topic. And if there's questions and things that I don't get to, or you want to chat further, please feel free to reach out to me online. This is a photo of a candy store in Barcelona when I was going to a Preventing Overdiagnosis conference there. These are people lined up for their happy pills. But I know that you don't want the sugar-coated version, just the straight up. So that's what I'm going to give you today. And we're going to be talking about tramadol and tramadol acetaminophen, which was developed in the 60s by Grunenthal in Germany and started being marketed there in the 70s and eventually came to North America in 1995. And you'll see this ad says it has an excellent efficacy and safety profile. So that's what we're going to unpack today. I have some questions for you, but we're not going to be using Slido because a lot of these are more thinking questions. Some of them have clear answers and some less so. So what do you think, first off? Is tramadol an opioid? No? Yes? Only after it's metabolized? Well, in order to answer that question, I think knowing a little bit about the pharmacology is very important. And it can be complex, but I'm going to try to give a simple version of it. So tramadol, the molecule, in an R and S enantiomer form, positive and minus, is somewhat of a prodrug, meaning that it has to be metabolized into some active agents to have its effect. And that's done through the cytochrome P450 system. And much like codeine, there's different rates of metabolism of tramadol based on a person's sort of genetic makeup of this system. Probably about 10% of people are slow metabolizers, and a different proportion, somewhere between 1 and 10, depending on ethnicity, 1 and 10% of people are ultra rapid metabolizers, meaning they may convert much more quickly into the metabolites, of which there are quite a few, probably not that many active in the bloodstream, but one of the key ones is M1, which is an opioid agonist, works on the mu-opioid system. Tramadol also works a little bit on these receptors, but M1 is about 700 times, or has about 700 times more affinity for that receptor. So that's probably the main opiate action through that route. There is also effect on serotonin and norepinephrine reuptake inhibition, and both of these systems, the opiate and the monoaminergic system, have impacts on how we experience pain. So in British Columbia, how often is this medication used? Well, not infrequently. About 130,000 people in 2019 got a prescription in PharmaNet for tramadol. That would be at a cost of about 9.5 million. And it's probably part of a bigger problem, particularly in the post-operative population. This is data from Canada, not just BC, but it shows about 70% of patients who have a surgery wind up being prescribed an opiate to take, which is a much larger proportion than in many other countries. And of those patients who get an opioid after surgery, about 20% of those are prescriptions for tramadol or tramadol acetaminophen. So the second question for you, this one does have a clear answer. Pharmacists will probably know this, physicians nurses maybe less so. This is about coverage. So is tramadol or tramadol acetaminophen on the general pharmacare program? Is it only on the palliative formulary, or is it not covered at all? Well, it's not covered at all. And it's more than a few turnips. So tramadol, if you took about this is tramadol acetaminophen, if you took about 5 tablets a day for 1 month, that's going to set you back about $150 a month. And an equivalent dose of morphine would cost just about $22. It is covered on the palliative formulary and through some other pharmacare plans. So just for comparison. So why do we prescribe so much of it? I mean, sometimes people think it's easy. You do not need your duplicate prescription pad for this, so it's convenient. And colleagues of mine tell me, well, you know, it's not addictive. It's safer than the alternative opioids, or safer than NSAIDs. And it is in some of the pain guidelines. And this made me want to look at tramadol, especially compared to other opiates, to see whether some of these things were true or not. Of course, because of the different mechanisms of action, tramadol has a unique side effect profile. That M1 metabolite certainly is thought to be responsible for the sort of opioid effects like euphoria, some analgesia, and the typical negative effects like nausea, constipation, and somnolence. This wouldn't be a tramadol talk if I didn't mention Dr. David Yerling, who's an internist in Toronto, and he feels that tramadol is dangerous, irrational, and you're going to regret it. So why don't we talk about the safety of this? Here's a question for you. Compared to other opioids like morphine, tramadol results in the trials with lower rates of adverse drug events overall, constipation and nausea, vomiting, just those symptoms, or is it both of those things? Let you think about that for a minute, and I'll try to walk you through some of the evidence. We know, of course, that compared to placebo, there are more serious adverse events in patients who take tramadol, but when it comes to opioids, you know, isn't tramadol better tolerated? Well, there was one network meta-analysis of opioid tolerability that compared all different types of opioids, oxycodone, morphine, fentanyl, tramadol, buprenorphine, and it found that there was really no difference in incidence of any adverse events across the different drugs. Mind you, that paper only included 2 trials with tramadol. Both of them were comparisons with buprenorphine patch, so I'm not sure how generalizable that is. In 2007, the TI participated in a review called a common drug review, and we also found that there was no difference in total adverse drug events in participants taking tramadol as compared with other opioids. The trials were small and short duration. Some of them were also analyzed in the Cochrane review on tramadol and osteoarthritis, and they found a similar pattern. So it seems that there's not a clear difference in levels of overall adverse events. There are some issues with the trials, and one of the major issues that makes everything hard to analyze is with study withdrawal rates. This is a lot of data. Hopefully it's the busiest slide of the day, and you don't need to look in detail, but this is showing adverse drug event-related withdrawals as compared with placebo, NSAIDs, and opioids in the trials. And I looked at the original FDA approval trials as well as the different Cochrane reviews. And in all of these groups, the patients who were taking tramadol had an increased tendency to stop the trial early. And that absolute difference ranged from place to place, but in the case of the opioid studies in osteoarthritis, there was a 17% absolute increased chance. So I think it's safe to say there's a significant increased chance of withdrawal due to adverse drug events. I'm not going to show you specific data about each side effect, like nausea in tramadol versus in other opioids and so on. But there are some signals in the literature that can interest people in this. They show there may be some increased nausea and vomiting, perhaps less constipation and less edema in people who take tramadol compared to other opioids. But those things just weren't borne out in the meta-analyses. All the pooled analyses in the Cochrane reviews showed no differences in specific side effects compared with other opioids. But the data it's kind of skimpy. The studies are really short. They're methodologically flawed. They have high risk of bias because almost all of them are funded by the manufacturer. And that makes things difficult to analyze. And the comparison of adverse drug events and tolerability probably depends a little bit on the specific opioids being compared, the doses being used, and patient factors. And those things are not always well controlled for in the studies. While the trial data is also not adequate to analyze some of the following outcomes, observational data signals some pretty strange associations worth knowing about. So going forward, I'm going to be talking about observational data, not data from randomized controlled trials generally. Both serotonin and opioid systems are involved in how we regulate our blood glucose. And there was a study in the US looking at events in their adverse reporting system, and that found that patients who were taking tramadol had an increased tendency to develop hypoglycemia compared to people who were taking SNRIs or opioids. There was also a retrospective review of hospitalized patients that looked at anyone who got a dose, at least one dose of tramadol, and had some blood sugars measured. And it found that in almost half of people with type 1 diabetes, there was a hypoglycemic event associated with the tramadol. That number diminished for type 2 diabetes and was just 5% in people who did not have diabetes. So something, if you're counseling a patient who has diabetes and is taking this medicine, something to think about. Another one that's not often spoken about is hyponatremia. Compared with codeine, tramadol is associated with an increased risk of hyponatremia, and that leads to a twofold increase in hospitalizations due to hyponatremia and tramadol taking patients as opposed to patients on other opioids. This seems to happen just in the first few months of use of tramadol, but not after 3 months. So maybe something that needs to be looked at in initial periods. Serotonin toxicity. This is not something that happens typically with use of tramadol alone, but when it's used in combination with other drugs that increase serotonin levels, like SNRIs or TCAs, that can lead to serotonin toxicity. Morphine, codeine, buprenorphine, those medications are not known to precipitate toxicity, but some of the other phenylpiperidine opioids like methadone and meperidine do. So it's not unique to tramadol. Looking at seizures, tramadol can cause a tonic-clonic seizure, usually when given a supertherapeutic dose, but doses as low as 100 milligrams have been linked with this. And I couldn't find any comparisons of tramadol versus other opioids in humans. There was one mouse study that said that potentiation of seizures with tramadol was equivalent in tramadol versus codeine, so for what that's worth. Probably needs some more investigating. Another question for you about a potential serious association. This is opioid use disorder. Do you think tramadol is associated with opioid use disorder? If so, is it more likely or less likely than with opioids like morphine? Well, when initially approved by the FDA in 1995, it was thought that tramadol was a much safer and less addictive opioid option. Since then, the thinking has changed, and in fact, the monograph has had to be adjusted to include a serious warning, which cites the risks of addiction, abuse, misuse, overdose, and death. There was one systematic review that concluded, quote, "The human abuse potential of tramadol appears to be different from and lower than other opioid analgesic medications." However, that review didn't have a meta-analysis, so these were kind of narrative statements, and the lead author was a consultant for Grunenthal, the manufacturer of tramadol. So I'll let you think about the veracity of that claim. There is definitely physical dependence and tolerance demonstrated in trials. There's similar withdrawal symptoms with opioids, but in patients who are withdrawing from tramadol, there can be a sort of atypical reaction that seems to include psychosis and a severe anxiety reaction, perhaps similar to withdrawal of venlafaxine. And there's some addiction vigilance data from France where they interviewed patients and asked why they continued to take the drug. And they said it was fear of withdrawal, fear of cravings, or that they wanted some non-pain relief effect of it, like anxiolysis, euphoria, or stimulation. There was one observational cohort study of about 360,000 people in the United States that showed in people who were prescribed tramadol post-operatively, those patients, as opposed to people who were given a different short-acting narcotic, were more likely to take the drug after 180 days. Another US population study showed that at 1 year, patients who were initially prescribed tramadol, about 14% of them were still taking it, as opposed to about 5 to 9% of patients who had been prescribed a different narcotic still taking that at the time a year later. And in those original FDA trials, there was significant difference in the number of tablets that patients took over the course of the study. So in the tramadol groups, the number of tablets escalated with time to a much greater degree than it did with morphine and codeine and the other comparators.
Jessica, just to let you know, you have about 5 minutes before the question period.
Okay, great. Regulation in Canada. Health Canada schedules tramadol as a prescription. They recognize it's an opioid, but it's not listed in the Controlled Drugs and Substances Act and the Narcotic Control Regulations. That's currently under review, and probably it will be changed. The use and the abuse of this medication is rampant. The WHO has deemed it an international crisis, and it's primarily a problem in North and West Africa and in Egypt. And interestingly, the populations in those areas have a higher tendency for that rapid CYP2D6 metabolism, so more likely to experience the opioid effects rather than the sort of SNRI effects of the drug. The ultimate outcome, death. In one retrospective cohort study of about 200,000 young people in Tennessee, it found that rates of emergency visits, hospitalizations, admissions, and death related to opiates was much higher in 12 to 17-year-olds who were prescribed tramadol than those who were prescribed hydrocodone, codeine, oxycodone, and so on. In a retrospective cohort study of about 89,000 people with osteoarthritis, people who were prescribed tramadol had a twofold increased chance of dying than people who were prescribed NSAIDs. Notably, though, there was no significant difference in all-cause mortality when compared to codeine. And then lastly, there was a population-based cohort study of patients with osteoarthritis over 6 months to see if they would develop an MI in the tramadol group as compared to others. And they found that there was a slightly higher risk in the tramadol group as compared with those taking naproxen, but the risk was a bit lower than people taking diclofenac or codeine. So I think we need a little bit more information there, and certainly the RCTs are not powered or not long enough to tell us about these important effects. Here's a complex question. I want to start talking about efficacy with our last few minutes here. So many patients are prescribed narcotics for chronic pain, and I'm curious to know what you think. If is tramadol more effective than placebo, acetaminophen, NSAIDs, opioids, or some combination of that? Well, there are several post-operative meta-analyses that find different things. One found that tramadol plus acetaminophen was equivalent to 1 dose of ibuprofen. Another network meta-analysis looked at all the non-opioids post-operatively and to see which ones could reduce the amount of morphine that patients needed through the PCA. And they found that the combination of acetaminophen and NSAID was the most effective, and then individual drugs like clonidine, NSAIDs, COX-2 inhibitors were kind of in between, and the least effective were single individual use of just tramadol or just acetaminophen. That's interesting. I want to draw your attention to the Cochrane reviews. So there were 3. The first was neuropathic pain. It was in 2017, and they included about 6 RCTs with about 440 patients, people who had chronic neuropathic pain from different causes. They weren't able to analyze very much. There were so few trials of reasonable quality, but one of the things they could compare was tramadol versus placebo with a threshold of patients reporting at least a 50% pain intensity reduction, which is a pretty meaningful pain reduction. And for those of you who know forest plots, this line shows anything touching this line, which suggests that there's no difference between the placebo and tramadol. This box is just slightly to the right, suggesting that tramadol might be a little bit superior to placebo for this particular measure. However, there was so much risk of bias in the trials that they had to downgrade their statement, and they felt there was low quality evidence saying no meaningful difference in the ability of tramadol to reduce neuropathic pain by 50% compared to placebo. That's about all they were able to conclude there. When it comes to osteoarthritic pain, I mean, neuropathic pain is complex, so maybe osteoarthritic pain would be a little bit easier to see an effect. Well, they found moderate quality evidence of no meaningful difference in the ability of tramadol and acetaminophen to reduce OA pain or improve physical function when compared to placebo. And this is the Cochrane 2019 review, which had about 22 RCTs involving mostly women with knee and hip OA pain, averaging about 2 months, and a huge proportion of trials with significant bias there. They did find moderate quality evidence that there was a 5% absolute improvement in the chance of improving physical function by about a threshold of 20%. And this is with the placebo, but I wanted to look at, like I said earlier, at active comparators to see specifically about opioids. In this slide, you'll see they compared tramadol and acetaminophen at the top, and this is patients' ratings of pain to see whether there was improvement. In this case, no difference. When they looked at tramadol versus NSAIDs, perhaps slightly favoring NSAIDs in terms of rankings of pain, and the same with tramadol, acetaminophen versus NSAIDs, really no difference between the groups. This is the opioids. They were only able to include 4 papers of tramadol versus opioids. They found really no difference in ratings of pain. And with tramadol, acetaminophen, the same thing. This is the pooled result, which again, maybe favors the active control, probably shifting towards the NSAIDs a little bit there. The evidence was not compelling, but they found no meaningful difference in the ability of tramadol with or without acetaminophen to reduce osteoarthritic pain when compared to NSAIDs or opioids. So a lot of people would argue that measures of pain are not the best way to capture improvement in the effect of the drug. So they looked as well at physical function. This is compared to NSAIDs. And again, probably no difference, maybe favoring the NSAIDs. They said there's really low quality evidence that there's no difference in physical function. Cancer pain, you think would be more, a really important area. Well, this was done in 2017, very limited data, tons of different comparators in terms of opioids. There was about 8 different active comparators that they looked at. 9 out of the 10 studies they included had a really high risk of bias in a couple of different areas. And so the Cochrane review concluded there was limited, very low quality evidence that tramadol produced some pain relief in adults with tumor-related pain, and very low quality evidence that tramadol is less effective at reducing malignant pain compared to morphine, and it was found similar to buprenorphine. And there's problems with this because I think actually the doses of the morphine in the trials were actually much higher than I would expect for comparison with the doses of tramadol used. Ultimately, when tested clinically, tramadol is unlikely to be an effective analgesic. I want to leave you with one perhaps ray of hope before we get into the questions. And this is, with tramadol, I ride like a jaguar. I talked earlier about some non-pain uses for tramadol, and this is an off-label use that you may see in some of the literature. The question is, are there sexual benefits? And very briefly, there was a systematic review and meta-analysis with lots of heterogeneity, short durations, problems with the trials, but they said statistically, yes. The pooled mean difference in intravaginal ejaculatory latency time, IELT, was 1.24 minutes when comparing people who took tramadol to people who took placebo. And they also said tramadol was reported to be linked with several tolerable adverse events, such as somnolence, pruritus, erectile dysfunction, and nausea. So I'll let you decide if that's going to be a drug of choice for those patients. We want you to stay tuned to the Therapeutics Initiative because we're going to be doing our own systematic review and releasing that information to you in the future. And I see Erin popping up. I wonder if I have 1 minute for pearls.
Of course.
Fantastic. So I just wanted to tell you what I do in my practice because I see a lot of palliative patients and others who have pain. The first thing is if a patient is already on the medication, on tramadol or Tramacet or tramadol acetaminophen, if it's working well, it's tolerated, they don't have any interactions, and they can afford it, I usually discuss it with them. discuss the harms and benefits, document those, and I send copies to whoever started the medication so that they're aware of some of those things they may not know. I usually offer to attempt to taper off or rotate to a more predictable opioid. And if they accept the risks and benefits and can afford it and so on, then of course they could continue it, but I would be more closely attentive to the adverse events. If a patient is not yet taking a drug and I'm considering prescribing a new drug, I usually don't think of tramadol first. I tend to prefer prescribing a predictable opioid. So if you're thinking of tramadol 50, I would use morphine 5 instead. And I think tramadol prescription is really only useful if all other options are exhausted, which has so far not occurred in my practice. And forgetting a duplicate prescription pad is not an indication to prescribe tramadol. I hope you enjoyed the whirlwind tour. I think there's just 2 or 3 minutes maybe left for questions.
Yes, and I wanted to thank you, Jessica. Fantastic presentation. You covered so much information in such a short period of time. Very practical. Many people commented that they absolutely love your slides, and I would agree. So let's get right to the questions. Clinically, tramadol seems to be more compared head-to-head as an alternative to Tylenol 3 than to classic opiates. For example, if a person has mild to moderate pain and is allergic to codeine, do you have any thoughts on that?
Sure. Some of the trials do include codeine and acetaminophen. We're including those in our systematic review. A lot of those trials were dental based, so sometimes single dose trials. I think tramadol has all the same and additional issues to codeine in terms of knowing how it's going to be processed, and it's going to have a very similar and even more complex side effect profile. So I don't see a justification for choosing T3 over tramadol or tramadol acetaminophen.
Great, thank you. Next question. Despite its misuse potential, would tramadol still have a role in treating neuropathies?
Neuropathy?
Mm-hmm.
Well, the study that Cochrane did about neuropathic pain said maybe not. I think if you've exhausted other treatment options, that's fine. In my palliative patients, I tend to use methadone because of that multiple equianalgesic effect, but methadone's been studied to a greater extent than tramadol. I'm not sure. I would say no, if you wanted a simple answer.
Okay, thanks. And we'll end with 2 questions. The first being, when combined with an SSRI, tramadol can cause serotonin syndrome. Is this well known and recognized? Pain and depression often go together.
Yes, I spoke about that earlier. Definitely the observational data says much higher risk. And I didn't show you a slide of the molecular structure of tramadol, but you'll be interested to know it looks very close to venlafaxine, has similar mechanism of action, they're commonly mixed together. And so I think if a patient is on an antidepressant that has serotonergic activity, I would consider an alternative analgesic medication for safety.
Okay. And the final question, in your opinion, is the prolonged use and increasing dose effect seen with tramadol a result of MDs and patients feeling it is somehow safer than traditional opioids, or is it an inherent pharmacological property of the drug?
Oh, that's a complex one. I think the best way to answer that is to think about our patterns of practice with all drugs. I think we have a tendency to say, oh, it's not working. That's because the dose is too low. It's not working. That's because the dose is too low, and to continue to go up. And that approach works in palliative care with narcotics, probably, although it's not been studied in quite the same way. The trouble with tramadol is you start getting into those serotonin and other issues like the seizures. So doses of 400 milligrams is sort of the cap, probably because of the SSRI, SNRI limitations. Our thinking is probably that more is better. But in reality, in the clinical trials, there is dose escalation. It's often limited by patients' ability to tolerate it. So I don't know about the psychology behind it, but I think it's pretty ill-advised to go much higher because you're going to expose a patient to significant harms beyond those thresholds.
Great, thank you. And we do still have time, so I'm going to do 2 quick things. On the syllabus, will your reference, on the online syllabus, will your reference list be available, yes or no?
Yeah, and I tried a different thing today with the simple, very simple visual slides, but below, so you'll have access to my slides and the notes, which is kind of some of the things that I've said and references for each one. And I'd really welcome you to email me or tweet me if you have other questions, things that aren't answered, or if somehow you can't access the slides. It should all be there.
Great. And one last question. What about patients with reduced renal function who really can't use NSAIDs? I find morphine, hydromorphone patients complain more of somnolence.
Yeah, certainly there's contraindications to NSAIDs. I think the studies that we're looking at don't include patients with renal failure. They're all excluded from these trials. So figuring out, is it really safe? You know, can you just put renal people on NSAIDs? Is it safer than tramadol? Probably not. You know, I suppose there could be a role, but the somnolence effect with most narcotics improves after a short duration. So I always warn my patients, I say in the first few days of this use, you know, morphine, you may be a bit drowsy. That will probably improve after 2 or 3 days of taking the medication. And in the trials, there was no difference in somnolence in comparing tramadol to other opioids. That said, every patient's different, but I usually start with those other narcotics first. I start with the lowest dose possible. And if it's not tolerated, consider rotating to another one, which may have a different side effect profile for them.
Great. Well, with that, Jessica will give you a break, and I always look forward to your presentations, and you did not disappoint. So thanks very much.